From the Asgard Company Studios in beautiful Wichita Falls, Texas, from the finest mind in the modern fitness industry, the one true voice in the strength and conditioning profession, the most important podcast on the internet. Ladies and gentlemen, starting Strength Radio. Welcome back to Starting Strength Radio. It's Friday, and you're here, and so are we. And we are here this weekend with my old friend Owen Kelly. Owen is an orthopedic surgeon practicing in Russellville, Arkansas. He's from Wichita Falls. And Owen and I have known each other 34 years. And we're buddies. We're buddies. Owen has got a very, very successful orthopedic surgery practice in Arkansas. And his specialty, I guess if you could say it's a specialty, is knee and hip replacement. He does knee and hip prostheses. And he's done lots and lots and lots of these. And this is a topic of interest to lots and lots of people because of the fact that the surgery is now available and you don't have to be crippled anymore if your knees and hips are worn out. The surgery, when done correctly, is very, very good. We have people squat with knees and hips all the time, and they're able to train productively and successfully, and they're out of pain. And so we're going to discuss this surgery today, and we're going to talk to the man about this. Thank you for being here, Owen.
I'm glad I'm here. Glad to be here.
Good to see you again. So you went to the University of Arkansas, went to medical school, University of Arkansas. Tell us about your experience and your practice.
So I went to the University of Arkansas in Fayetteville for undergrad, and UAMS in Little Rock for medical school, and then I trained at the VA hospital, at the Arkansas Children's Hospital, and UAMS in Little Rock, and then I've been practicing in Russellville for nearly 17 years. I'm a board-certified orthopedic surgeon. I recertified in 2015. My practice, being a general orthopedic surgeon in a smaller area, where there's not a lot of specialty, I can kind of guide my practice where I like it. So I do lots of most of the joint arthroplasty or joint replacement surgery, and then lots of the trauma in the area. I try to stray away from a lot of the sports stuff. I do it, but I have a more of an interest in joint replacement and trauma.
Right. So somebody comes in with a compound fractured femur. You deal with that.
I love that. Yeah, I mean, I don't love that, but yeah, I like it. Yeah.
You like the way it looks. when you go in the ER and there's...
I like the physical aspect of...
You like to solve the problem.
I like the physical aspect of orthopedics. I like the bigger stuff. There's obviously the arthroscopy and the ACL stuff, and the stuff that's more kind of in vogue with sports is I do it, but it's not my favorite thing to do. Right.
And we'll talk about the meniscal repairs later, because you need to hear this, boys and girls. So knee and hip replacement. What is the history of that surgery? When did that all start?
Oh, I don't know the exact time, actual year, but actually hip replacements, Dr. Charnley in Europe started, and he would actually put a plastic polyethylene cup in, cemented it with bone cement, and then he would cement in a metal prosthesis into the thigh bone. And I think over the when he started doing his, now he's not the father of it, but he's the one that really started it.
When was this?
I can't give you the exact time. I apologize.
70s, probably?
Yeah, 60s, 70s, because Carl Nelson.
It's been a while.
Yeah, Carl Nelson, who was our chairman, trained with, he started at Arkansas in 74, and he trained with him before that. So late 60s or early 70s. And he had a significant failure rate, obviously, but that with
prototypes
medicine,
being what they are.
And so he eventually perfected it, and then it's advanced from there to now, where you do what we call a press fit hip, where the implant is placed into the thigh bone without any bone cement. It basically gets stuck in there, and the bone grows in. And the same thing with the acetabulum, which is the socket part. It grows into the socket as well. And implants have gone through their stages of what's kind of in vogue, but it's pretty much stayed about the same.
What about knees? When did that start taking place?
I'm not 100% sure, but 68. So late 60s, early 70s. There you go.
Our research assistant.
Yes. So it's. I think the natural history of knees isn't as exciting as it is with hips, but it's the same type of process. And we really different from the hips, and we can go into this. Most knees are cemented in with bone cement, whereas most hips are press fit. And that's not an absolute, but that's what the majority of people do.
So the technology of knee and hip replacements has essentially been advanced through advances in the prostheses themselves. The surgery, is it fair to say that the surgery has not evolved? The surgery has evolved as a result of the development of the prosthesis.
Yes, and there is some technology in it, but I would say over the last several decades the change in the implant is there's small changes, but they're not big. The approach to a knee replacement is the approach to a knee replacement. They've tried it different ways, but it really doesn't change. The approach to a hip, there's an anterior approach, anterior lateral approach, direct lateral, posterior approach, but the approach to the hip is it hasn't changed either. They're the same surgical approaches that you get to the knee and get to the hip and other types of surgeries too. So and it's just kind of surgeon dependent. What surgeon choice? What type of approach do you want to do to the hip?
So who actually develops this technology? The companies involved in it, or are they working with you guys?
Yes, there are lots of physicians that like to be involved in the process of implant design, and it makes a big difference, especially the big joint replacement guys. That's all they do in the big centers. They can make some impact on types of implants, and it makes a big difference. But really, the implants that I use, I've been practicing for 17 years. There's been some small changes, but nothing drastic.
Right. And Biomet and Stryker.
Yeah, Biomet, Zimmer, Stryker are
the two big players.
Yeah, two of the big, probably three players. So there's some other ones that get thrown in there, but they do a significant amount of the joint replacement.
There's a lot of money in this. I guess that these companies have invested a hell of a lot of money in the production of this equipment and technology, and I guess they're probably in a position to spend a lot of money on R&D. And
yes,
that's probably a good thing, isn't it?
It is. I mean, competition is good. I mean, it makes things better. And people say, well, that implant isn't any good, or that, that's not true. Most implants out in the market today, if they're not any good, nobody's using them.
Right.
So if whatever type of implant, whatever surgeon chooses to, whatever type of implant he or she uses, it's going to be a good implant that's been tested. I mean, that's the one thing about the United States.
Nobody wants to be sued.
The United States, they try to make things safe. You have to. There's a lot of legal stuff, but it does give you a lot of safety, especially with what we do.
Right. Don't go to China to have this done. Okay. Stay here to have it done. One of the interesting things about these types of procedures is that you and I really don't know what the hell happens between the time they put us to sleep and the time they wake us back up in recovery. So, Owen, tell us what the hell goes on here on a hip and on a knee. Let's start with a hip. They wheel me in. I'm out. Anesthesia's already been done on me. I'm out. They wheel me into the OR. What happens next?
All right, well,
what do you do?
Let's back up a little bit before
Okay.
that. You come to my clinic. You have some hip pain. People believe hip pain is here, and I know you probably can't see me, but your hip is your growing in your thigh.
Yes.
Hip pain is your growing, thigh pain. One of the main complaints people come in when they have a hip problem is they have thigh pain. They think it's their knee because they have this aching knee. They can't pinpoint it. You come in, we x-ray you, standing x-ray. We find out you have bone-on-bone arthritis. You hear arthritis thrown around. What arthritis means, if you take it and break it down, arth means joint, itis means inflammation. So you have an inflamed joint. Arthritis really isn't a condition of having something. actually you don't have something. You don't have your normal joint cartilage. Your car may be in good shape, but your tire's worn down. That's the best way to explain
inflammation has eaten away the cartilage.
It is. And
now you've got arthrosis.
Right. And so you have, instead of a nice smooth surface for your hip or knee or whatever is moving, now you have a painful joint surface. So we have that. We give you your options, which for hip arthritis, it's minimal. You can put a cane in her hand, take anti-inflammatories. If it's bad enough, then hip replacement. So we sign you up, make sure you're medically clear. It's an elective surgery. We don't want to take you to surgery if you have some health issues that haven't been worked out. Most of the time when you have your hip replacement, you're a little bit less young, so there can be some heart issues, diabetes, a lot of it. So we get that cleared up. You come in, most of the time you go to sleep. And it depends on what your surgeon choice is. What approach is he going to do? Is he going to do a posterior approach? Is he going to do an anterolateral approach? Is he going to do an anterior approach? That's just surgeon preference.
This is how they get
how they get to your hip.
To the hip.
So,
right.
All right, I'm going to bring a model. So this is your hip, guys. This is your hip. All right, that's your pelvis. The best way is this is where your belt line is. But when you put your hands on the hip, that's it. So here's the ball. Here's the ball and socket joint right here, hip. If I
turn him around.
If I dislocated your hip, there's the socket part. There's a ball. The red shows you your weight-bearing surface. There's not much left in there. Okay, so we go down to the hip. You dissect down to the hip, and you dislocate it. Okay,
so you're gonna flay the skin back.
You go through the skin. You go through the fascia. I go through an anterolateral approach, so I take the abductors off, which move your leg out to the side, and then I put retractors around the front of the.
You take the adductors off.
Third of them. Take a third of them off the greater trochanter.
Off the trochanter.
And I've elevated up. At that point.
Right, the anterior side of the greater trochanter.
So really, I'm going in through anterior, but going through an anterolateral approach. Okay. We find the capsule, which is the overlying layer. It's like a water balloon. What covers the hip, and we open up the capsule. Every time you open it up, if you got a bad joint, it's going to be filled full of blood or fluid or loose bodies
of some sort.
You dislocate the hip, okay? Pop it out of the joint.
Now, there is an femoral ligament.
Yes.
Right?
Yes.
Is that going to be intact in a patient like this?
It's a little bit more medial. It's a little medial, so you try to stay. Most of the time, you can retract it and get it out of the way.
Right.
Okay. But when you get into the hip after you dislocate it, then you cut the top of the ball off. Bam, it's gone.
So the ligament's now gone.
Part of it is gone. You have ligament structures in there, but then you have
the capsular ligaments.
Yes,
is what we have left, right?
And so there you are. You take a reamer. It looks like a cheese grater, like a circular cheese grater. You put it into the acetabulum. Yeah, put it into the acetabulum. You turn it on, and you ream it. Okay,
like with an electric motor.
That's exactly right. It's a drill. Once it's out, then you have a hole, and you've measured it. Your reamer. A lot of this is some art. Now there's a lot of techniques that people use now. They can measure it directly without them having to ream it, but it's reamed out. Then you put the artificial implant in. It's not this, obviously Then you put an artificial implant in there. It's stuck. It gets stuck in there. You hit it in with a mallet and it gets stuck. And so once that...
I'm glad I'm asleep for this.
Yes. Once that's done, you expose the femur, expose the top of the femur, and you rasp it. You take a rasp, and it looks just like a hip replacement, but it looks like a rasp, okay?
So we've already cut the head of the femur off.
Gone. Right.
Femoral, neck, everything, all that's gone.
Gone. There's your cut.
And now we've got...
that. You ream it out, which means basically... First thing I do is I take this thing called a Ben-Hur reamer. You've seen the movie Ben-Hur when they have the chariot with the thing that goes in there, it opens it up, and then I take a lateralizing device, which goes right down the canal. It'll tell me where the canal is. Then I take rasps. They look like this implant, but they're like you're filing something. You put them down there until you get a good fit. Once you feel like you have a good fit, I have X-ray in the room.
So you're going to rasp the hole, size it.
Till something's stuck.
Till something sticks. Right. If you can't get it down, if you can't get the implant down into the into the cavity, then you continue reaming it just like you would size anything.
Right. And it's technical. It's just learning it. Once you get the implant that's right at the edge here of right above the lesser trochanter in the medial calcar area, once it's there, you got a pretty good fit. I get an x-ray. Some people don't. I get an x-ray. I use a C-arm, which is a fluoroscopy. It's a real-time x-ray.
Right.
And I look at the implant. I'm like, I like that. I like it where it sits. Once you have the size that fits and you have a neck length and head length, then you put your implant in.
And this is how long this thing is.
The thicker it is, the longer it'll be.
Mm-hmm.
Okay, so it goes in. It's stuck in there.
And how do you choose the size of this? This isn't a nail, but this is
You choose this size by what size it's stuck in there. Okay, so that's size. Now, there's different.
Does this vary with the patient?
Yes, there's different neck lengths.
Right.
There's an offset stem.
So a 120-pound female is going to have a different implant than a 250-pound male.
And what is opposite is that your implant goes into your canal. So a 120-pound lady who is osteoporotic is actually going to have a wider canal. Mm-hmm. Not a bigger bone, but a wider canal because her cortexes probably aren't as thick.
Right.
So she may get a bigger implant than a 250-pound man. Yes. Yes. Because
and that would be to her advantage because now there's more surface area, bone in contact with the implant.
So the implant isn't based on the implant isn't really based on the size of the femur. It's based on how much medullary canal is in there. Mm-hmm. So if you have a big, thick cortices, then you beat it. You can beat one in there that's bigger, but it ain't going to work.
Right.
Certain implants have and this is very technical, but have a high offset. Okay, if you have somebody who doesn't have very good muscle mass and you're worried about dislocation, then they'll do an offset stem. So this will actually be over here. So what that does is it gives you a tighter hip by pulling on the abductor muscles, but not lengthening your leg.
It just changes the mechanics of the way the hip relates to it.
So two ways to make it tighter or to make the neck longer, push it farther out, or to make the abductors tighter. Well, if you already have equal leg lengths on your x-ray, when you have the implant in, you don't want to make her tighter by making the leg longer. You want to do it by pushing the leg out to the side and letting the abductors. And it's all, it's force and it's once you do enough and you kind of get used to it, it's just second nature to you.
So do you ever have any trouble in osteoporotic females with a fracture when you try to emplace
if you're not breaking a couple femurs a year, if you're not cracking them, you're not putting them in tight enough.
Right.
And so we have cables on the foot. I know that sounds crazy, but you put a cable around it like this. If it
before
cracks.
You put the
after you see it crack, you take it out, put a cable on it,
reinforce the fracture,
and put it back in. And you can weight bear on
and
that.
It'll heal.
Weight bear on it immediately. Wow. You don't restrict them or anything. It's
that's interesting.
It's just part of the process.
Right.
Once you get the implant in, you reduce it, which means you push it back in joint.
Turn it around so everyone can see. Now, you have in effect reduced the surface area of the femoral head in contact with the acetabulum.
Right. And it used to be when I was in training, we would have 22 millimeter and 28 millimeter heads. The metal-on-metal prosthesis, you could have heads that were basically I think they were 8 millimeters below the size of the cup. So if you had 50 cup, you have 42 head. I mean, they're big. So the risk of dislocation was very low. But now that most people go ceramic on polyethylene or they do metal on polyethylene. The head. There are some bigger heads, like 32 millimeter heads, which I'll use, and some 36 millimeter heads. Most of the heads are not bigger than that. So the bigger the head, the more circumference you have, the less likely dislocation rate you have. And dislocation rate is also directly related to the approach you use.
So the dislocation rate is a function of the size of the ball and the cup, and it's higher the smaller the size is, right?
But dislocation is basically, I think it's more of a function of implant placement, because if you put the cup in a little bit, what we call anteverted, you can have different areas where the ball will come out. In 17 years, I think 3 times I've had trouble with that and would have to go in and put the cup in a different position. A posterior approach, doing a posterior approach, more people put more pressure on the hip posteriorly, especially when they're getting off a toilet or getting up from a chair. So with a posterior approach, it's more likely to dislocate because posterior is more unstable.
Right. So if I'm going to squat on this implant, prefer an anterior.
Absolutely. Anterior lateral approach. Right. Yeah, absolutely. And with a fracture, because this is logistic, once again, this is way branching out, but like if you do a hip replacement for somebody that broke their hip who's an active person in their 70s, you would want to do an anterior lateral approach, because if you do a posterior approach for a hip fracture, the chances of dislocation, I think, is 3 times what it is if you do an anterior lateral approach.
Right. Well, while we're talking about the prosthesis itself, you had mentioned a metal-on-metal approach where you have a much larger ball,
right,
much larger replacement femoral head,
right,
and a much larger cup, much larger replacement acetabulum. Why are those not used as much anymore?
Well, about a decade ago, maybe less, there were some problems with one type of implant, metal-on-metal implant, called metallosis, which basically means that the metal ions were wearing down, causing metallosis.
Coming out into solution. And
right. That was basically based on if the cup was too much, I believe, antiverted, which means it was too open. So you had too much metal irritation, and don't quote me on this, but too much metal irritation or metal movement on the rim of the cup. And so they took it off the market. Well,
that sounds like a metallurgy problem more than a mechanical problem.
Right, and it's more of a placement of implant problem.
I mean, they could fix this to make a more inert
probably
prosthesis if they wanted to. It would seem like to me. I mean,
the bigger the head, and I liked doing. I did specifically only metal on metal for a long time, and then when they started taking them off the market, they wouldn't let us do it. I mean, the surgeon that did my mother's hip replacement in the Dallas-Fort Worth Metroplex, I talked to him, and literally he had done thousands of them without any problem.
Metal on metal.
Metal on metal.
Is it still available if you want it?
No.
Really?
It's not available.
It's not even available now.
Not even available. In fact, I had a gentleman that had done a metal on metal on, and he fell and dislocated his metal on metal hip. So I had to revise his hip to he actually broke modern. The implant, popped the head off, and he did the splits, and so I metal on metal was not available, so I had to use a special type of plastic head that big polyethylene head that looked like one, but it wasn't metal. So
you didn't have to revise the acetabulum.
No, I didn't have to revise the acetabulum or the femur.
Just
the head and
head
neck,
of the implant.
Head and neck, yeah.
Well, that's interesting.
It's fortunate.
So, how much less stability do you think this thing provides in the absence of the iliofemoral ligament tying the thing together? I mean, that seems like a mechanical problem that could possibly show
could,
up.
but when you do a revision on a hip, which means when you go in and revise one, take an old one out, put a new one in there, you're not opening up the joint and it's full of air. I mean, there's soft tissue everywhere.
Right.
Surrounds it completely.
The whole thing is being held together with muscle tension.
It's soft tissue. Right. There's scar tissue. So your body learns for the range of motion it needs, but everything else in there kind of locks it down. So stability with implants it's an occasional question. It's not a very common occurrence anymore because implants, just techniques and approaches have changed and have improved. So it's not an issue. I would say that.
And I would also venture to guess that somebody with a hip implant is going to tend to protect the hip as well.
Yeah, but
you don't go jumping off of buildings.
No, but what you do hear from people is they'll say, "I forgot about it." Because it feels so much better.
Yeah.
I don't even remember.
Yeah, I guess that's true.
Yeah.
It doesn't hurt all the goddamn time like it used to. And
right. It's a quality of life issue.
Right.
You know, if you got a pain problem, you know, that's what a hip and knee replacement. I tell you, I don't save anybody's life. I don't do that when you're doing replacements. You're not saving somebody's life. You're improving their quality of life.
Sure.
Right.
Sure. This is important, and we're going to come back to that. This is a very important aspect of this discussion. So you get the implants in place. You got hip done. You got femur done. And now what happens?
Close them up. You either
take the
sew the
retractors
abductor.
off.
If you're doing a direct anterior approach, it's just a muscular. If you're doing a posterior anterior lateral, you take the abductor, you sew them back. You close the...
Sew them back onto the
sew them
issue.
back tendon-wise, some people use sutures through the bone. It's technique-wise, however you want to do it. And then I close the IT band, sub-Q skin, recovery room, get them up, walk them the next day.
Do you split the IT band? Or,
yes, split it. I do. Split it right down the middle.
Right down the middle to make room instead of cutting it.
Right. I just split it and
across.
I retract it. And once you split the IT,
that doesn't really affect its strength at all, does it?
Not at all. Not at all. Incisions heal side to side, not end to end.
Right. So then they wake up in recovery, and they're in there about an hour, and then they go back to the room, and then.
Well, and some people do it differently. I try to give them the first day off, and then the next day I get them up and walk them. That's it. With a hip replacement, recovery, a hip, I tell people getting up and walking. Get up from a seated position and walking is the best rehab you can do. I limit abduction for 6 weeks. I don't let them do active abduction, which means use their own muscles to abduct them.
That way they
protect
you let the adductors heal.
You let them heal. Most people with an anterior lateral approach will have a little bit of a painless, most of the pain from hip replacement, the surgical pain is gone with somewhere between 2 to 6 weeks. Most people are regretting their surgery the first 2 weeks. They forgive you about 4 weeks. By 8 to 10 weeks, they really love you.
Everything's fine.
They'll have a limp.
What causes the problem? The bone?
Yeah, taking the saw and cutting your bone, that
hurts real bad.
Hurts. It does. It hurts. And it's hard to explain to people how bad it hurts. But with an anterolateral approach, they'll have they'll have a little bit of a limp. I can notice it. Most of them don't notice it, but I can see them limping, and usually that limp is gone at 6 weeks. And there's lots of not controversy, but there's lots of debate on what approach is best. And this is what pick a surgeon you trust and you believe in them and has done a good job for you. And don't worry about what approach they use. Just pick somebody you trust, and they'll do a good job for you.
There's probably an argument to be made against a posterior approach, though.
There's an argument to be made against every approach.
Right. Against the surgery itself.
I mean, the posterior approach is it used to be very, very common. People do it. It's a good approach. People have good results with it. An anterior lateral approach, the same way. The anterior approach was kind of the new in vogue thing. But there's negatives to every single one of them. And so the negatives aren't on the patient. They're on the surgeon.
Right.
What does your surgeon feel that he's best able to do? I've done posterior approach and anterior lateral. I feel best with anterior lateral. That's how I trained. I have my results for me are good for me. I don't badmouth somebody else's technique because it's not something I like.
If you go in anterior, how long is the incision?
It just depends. It all depends on patient size, patient anatomy. Anterior approach is kind of the new in vogue. You have to have a special table to do an anterior direct.
Oh, really?
Yeah.
You don't just lay on your back?
You do, but you have to extend the hip about 90 degrees to dislocate it. Straight back extension.
Oh, God. So the torso is elevated?
No, you're flat. You're flat, and then you take there's a special table, and
you got the drop on the table.
Drops it down. And you drop it, and it extends it, and you cut it.
So you're standing where? Next to the patient?
Right next to them it's just right over the top. And
so they're at chest level to you?
Yeah, chest or whatever, whatever height you want. Plus, on the anterior approach, you have to special acetabular reamers, and you have to do it under X-ray. Most people do.
Yeah.
Whereas an anterior lateral approach, posterior, you have direct. But with an anterior approach, your reamer, when you're reaming, they have to be curved to get around the anatomy. And there's certain guys that do it. There's colleagues of mine that are they're joint specialists. That's all they do. A lot of them like the anterior approach. They've done it enough. They feel good about it, have good results with it, and they do a good job. And
how long does it take, relatively speaking, between the three approaches? Is one of them shorter?
Well, everybody's different. Traditional anterior lateral approach that I do with a patient that is average size in Arkansas, that's a little bit different average size. I can have implants in and be closing somewhere between 35, 45 minutes.
Wow. From first incision to close.
Well, yeah, from getting down to exposure to that, but closing takes 15 minutes, sometimes 20. Anterior approach probably an hour. Posterior approach, about the same as that.
Right.
The exposure is the exposure is really not the difficult part of it. You know, the difficult part of it is making sure you have one that fits, getting the X-ray in, making sure. But when you have a team, you're only as good as the people you work with. So if you have a good team, they can make you very efficient. So I've got a team I've been working with for a long time. They're very efficient.
So do you close?
Yes.
Or do you just do the?
I don't have a PA, a physician assistant, or a nurse practitioner. I change my own bandages. I do all.
You
that
do
stuff.
the whole procedure from open to close.
Yes.
Right.
Yeah.
Because I've heard some people do the implant and then they walk off and let the
colleagues that have physician assistants. That's what they do. They close all their wounds. I don't do that. I don't. There's a I just don't. I choose not to. Doesn't make it wrong or right. Just makes it what I do.
You just want to make sure that the whole damn thing is your work.
Right. And and there's always complications with everything. There's a complication rate every surgeon has. Everybody's about the same, and it just happens. Complications are part of the risks of doing surgery.
Right. Now, what about a knee? Which would you rather perform? Are you ambivalent about it, or you like hips better than knees?
I'd rather do all hips.
Really, knees are
hips,
more variables. Huh?
Yeah, they are. Hips do so much better. The problem is, and this is it. I mean, if you're going to do them, you have to take care of the complications, and knee complications. Revision knees are a little bit
probably more common than hip revisions.
Than hip revisions. Hip revisions are difficult, and if I have trouble, I'm not too proud to say I got a colleague of mine who does lots of. That's all he does is revisions, and I ask for his assistance and send them to him to do. But I like hips. Patients, I tell people this: you can do the two most patient-satisfying surgeries, and this is by studies: carpal tunnel releases, hip replacements.
Right.
Because
now you're not hurting anymore.
And if you've ever had
very important.
If you've ever had hip pain, it's miserable. I mean, and people are miserable, and they're angry, miserable because you can't get comfortable.
No.
A bad knee. You can prop it up, put some ice on it. You can't. Your hip, you can't prop it up because you're propping up your body.
Right.
And it's a big joint. So hips hands down. Now on to knees.
Let's talk about how we do those and same kind of thing.
Same kind of thing. So knees can be looking at a knee. If you're going to get a traditional total knee replacement, there's a lot more variables on the implant, okay? And I'm going to try to make this as simple as I can.
Okay.
There's the three basic types. There's a posterior cruciate retaining, okay? And this is a total knee. This isn't like a unicondylar.
Where you save the posterior cruciate ligament.
There's a posterior cruciate retaining knee. There's a posterior stabilized knee. And then there's a constrained knee, okay? Now, you can throw a fourth one in there, which is a linked or prosthesis that's actually attached together, like a hinge.
Right.
That is a bearing in there that does not separate. A constrained, a posterior stabilized, and a posterior cruciate retaining.
Do we ever retain ACL in one of these things?
No.
Just not possible.
We don't. Here's my, and this is my thinking on a posterior cruciate retaining. I do a better job. I can recreate a posterior stabilized knee better. The problem with a retaining knee is that a lot of times, not all the time, but a lot of times if you've had a PCR done, the native PCL that you maintain loosens over time. So you have people that
because it's under so much more stress.
So people develop instability posteriorly 6 months, years after it when they've had an excellent surgery done. They're like, what's going on? And the problem is they've had a PCR. And so you have to revise that to a posterior cruciate.
Now, for everybody watching us here, anterior cruciate, here's the femur, here's the tibia. Anterior cruciate keeps that from happening.
The anterior cruciate ligament.
Tibia translating forward relative to the femur. Yeah. And PCL prevents the opposite from happening. So this is posterior instability.
Right. So ACL prevents anterior translation of the tibia on the femur.
Right.
And it's at 30 degrees of flexion, that's when it's really just your ACL that's doing it. I mean, that's when you see, if you've ever watched ESPN, watch somebody go down, or watch a basketball game, they come down and they do a Lockman's test. They're checking it, and that's just for show, really. But they could do it on the sideline. And so posterior cruciate ligament is posterior translation. And how I explain that to people, a common way to injure your posterior cruciate ligament is if you're in a car wreck and the dash hits you below the knee,
And
takes your tibia, and
shoves
shoves it straight back,
Right.
and so you have posterior. Now, a posterior cruciate ligament is not as vital to repair. You can rehab a knee and make up for the deficit. The problem is when you if you have a insufficient posterior cruciate ligament after a knee replacement, you don't have muscle strength and stuff doesn't play as big a part in helping that stability. So I do a posterior stabilized. I'll explain that here in a minute. So you come in, they get you signed up for surgery, and basically people think that you've taken the whole knee off, but you're not really taking the knee off. The best
Not anymore.
No,
right?
you're basically, it's like a bad tooth, like you're crowning a tooth. You're taking off the layer above it. So,
You're resurfacing,
right.
basically.
So this is what you're taking. You're taking about this much off. And this is a posterior cruciate retaining. I'm sorry, I don't have a posterior stabilized. So that's what it goes on. So it's not like if you look at it from the side view, I mean, you got a metal layer there. From the front, it looks like the whole knee is made of metal, but it's not. So then you take the top of the tibia off, and there's all cuts done. You have a measurement guide. And then you place the tray in here. The polyethylene, which is this,
and this is actually the substance.
That's the real deal.
This is what you're placing.
High density
plastic.
It is, and it's
very slick.
Yeah.
The attempt is of course to recreate a frictionless surface.
Right, and so the normal wear I think it's 0.01 millimeters a year.
Oh, really? How does this thing withstand compression?
It stands compression well. I have people that overdo it.
Well, yeah, I know a couple of those.
In my mind, but
our friend Phil Anderson.
Yeah, he's had both of his knees replaced.
He is not a smart person.
So that's what you do. Now, posterior cruciate stabilize that I use has a little plastic post in here that goes in here, and what that does is it prevents posterior rollback. So with it, your knee can't go this way.
Turn them so we can.
Yeah, so when the notch is there, it's posterior rollback, which means when you do that, it won't dislocate.
Right.
Okay? That's a stabilized. A constrained just has a thicker plastic post in there. So it also gives you, because when you're doing a revision and you need a constrain, your collateral ligaments, they're obsolete. They're no longer there.
Really?
They're scar tissue. So you want something that
I guess if you pull the whole damn thing apart, the MCL, LCL have to go with it.
Well, yeah, or they're scarred in and they're incompetent. So now you have medial lateral stability and you prevent that. Now, if you get to the point where you have a tumor prosthesis, which is a hinge prosthesis, or you're doing another revision, which basically means you're losing lots of bone, then you link it together, and I mean you can replace an entire femur if you have to with a metal.
Really?
Yes, you can.
The whole femur.
You can do it. The tumor guys, they do it all the time, and
they've got a titanium femur.
A whole femur.
Wow.
Yeah, those guys are slick. I trained with Dr. Richard Nicholas.
How do they
in UMS during my training?
The adductors to the medial diaphysis of a fucking titanium femur.
They don't. It just scars in.
Wow.
And then Corey Montgomery is a tumor guy. He's an orthopedic oncologist who's Richard Nicholas is, and he does it all. I mean, those guys are slick. They are slick.
That is amazing.
It's amazing.
That's amazing.
And the joint guys that I'm not pubbing these guys just because I know them, but Paul Edwards and Lowry Barnes are the head of the joint, and Simon Mears at UAMS. They're the academic guys at UAMS, and they do all that kind of stuff too. They do all kinds of prosthesis. It's impressive. It's an impressive thing. It's an impressive, very much so. I give credit where credit is due.
So let's start like we did with the hip.
Okay.
Guy walks in the hospital. He lays down. We put him in a white gown, embarrass him,
So we
have him tie that thing in the back. He lays down. They tell him count backward from 100, and he gets to 99, and he's asleep, and he's in your OR. What do you do now?
Put a tourniquet around his leg. Okay.
This is an interesting thing. You have to do that to control the operation site, right? You don't want blood pouring into the
And the knee is, a hip is with a hip you can't do that, but you try to lower pressure during a hip so that there's more, there's not as much blood. But with a knee,
there any procedure you can do for a hip to reduce the perfusion through the thing?
Hypotensive anesthesia.
Oh, I just do it with chemistry.
Yeah,
right.
Hypotensive anesthesia, which means lower your blood pressure.
Right.
So you put a tourniquet high on the thigh, and I explain to people, when you get your blood pressure taken and it hurts really bad, that's about 250 millimeters of mercury, and it's up for what, 3 seconds?
Yeah.
We would put one on the thigh at 300.
Right. And leave it there
20-something minutes.
For 20 minutes.
Sometimes an hour.
Right.
So you can imagine the muscle pain people have when they wake up.
Sure.
So you do an anterior approach to the knee.
But while we're on that, what happens if you're not perfusing past the tourniquet? I know we got to keep the blood out of the open knee wound and everything, but what about the tissue? Is necrosis ever a factor in a situation like this, and why not?
That's an excellent question. Less
than
an hour.
Right.
You're
okay.
You're okay. But if it goes past an hour, a lot of people will release the tourniquet for about 10 minutes.
Let it
perfuse, and they'll rewrap it, put it up again.
Right.
And so that's
and you're okay like that.
You're okay.
Right? Let's say we've got unusual things to do down there.
Then people will do that. And then some people, because after they'll do it, some people will put the tourniquet down an hour and just neutralize any aggressive bleeding, and then do the remaining surgery without it.
Oh, really?
And I know some people,
it's
rare. I've done I think in 17 years, and of all the joints I've done, there's been 3 times that I've just said take tourniquet down, because it's such a venous tourniquet. They have a lot of fluid around their leg. You wrap it, and all the venous blood has stayed down there, and it just you can't see. You put it down, you stop the big bleeders, and then you do the knee replacement with it without a tourniquet. So I've done that a couple, but there's some people that do that. Some people that, not many. I mean, not many, but I've heard of it and actually read articles where people have done that.
Right. Well, I'll come back to that because I've got a question about the effects of the tourniquet post-op. But so we've got the tourniquet on, and now the knee's painted with betadine, and you're going to cut the guy open.
So we zip them. We use an S mark, which is like a rubbery ace wrap. Get the blood out of the knee, put the tourniquet up, make a direct anterior approach, and then we do a medial peripatellar approach, which means we find where the quad tendon, patellar tendon, and we do a medial approach where you invert the patella. Okay, I do what we call,
because we have to keep the patella.
Yes,
we have to keep the patella and the quadriceps tendon and the patellar ligament,
or you won't straighten your leg.
Or we don't have a functional leg.
Yeah, and there's no need to have a leg if you can't straighten it.
Right, exactly.
So we do what we call, I do a medial peel, just take the medial tissue off the top of the tibia here. There's a fat pad in the front, right in the front of the knee. I take about half of that off. Then I invert the patella, which means you take the patella and
lay it to the side.
Place the knee on extension. Then I take a saw. A lot of people use a guide to cut the patella. I do it freehand. Take a saw, put something, and do it. And then you actually replace the patella with a button. Looks like a little plastic button like that.
You replace the patella?
A third of it. The undersurface.
Oh,
of the
okay.
patella.
Okay, so you've got plastic on metal. Okay, right. Not cartilage on metal. Okay.
So then I do the tibia first. I place an extramedullary, which means a guide outside the internal aspect of the bone. Some people put one down in the middle. I do it on their ankle. You cut it perpendicular to the tibial shaft. Cut about 3 millimeters, maybe 4, off the most diseased side of the knee, which the majority of the time is the medial. Make your cut, take that out. You enter the femur, and I cut a 6 degree, between a 5, 6, 7 degree valgus cut of the femur, okay? All femurs are valgus, which means a little knock kneed, from about 5 to 7 degrees.
Because of the Q angle out of the hip.
So put it in there. I cut, it depends, and this is all, once again, you learn this. If they have a extension contracture, which means they can't straighten their leg out, you can clean out more posteriorly, or you can cut more femur. You measure that before. You cut femur. I cut between 11 and 13 millimeters. Once you cut that, then you measure it. Put a measuring device. Okay, it's not like we have an implant that's sized. Now, some of the other techniques with robots have them. You size it. They got all the sizes. You pick your size. You'll
have a variety of prostheses on the table.
Not on the table. We'll have sizes, but we have
available.
Right. So, and I do a posterior stabilize. So I cut a box in the end of the femur to allow the box to be put in there.
See what that looks like.
I don't have it, but it's a box that's cut instead of what you're looking at here. posterior stabilizer will have a box cut that goes all the way through there. Okay. So
but you've got that facet cut and that facet cut and this facet.
Well,
cut.
we have the medial lateral from the
to
condyle
match the
and the trochleus
angles in the.
So it matches it. It's just it's like a mold. Stick your hand in a mold, pull it out. You got a mold. You get your hand, just it fits it. Then I put the knee out extension, remove the remaining portion of the medial meniscus, the lateral meniscus, and the posterior cruciate ligament. I take it out, completely out. Save the MCL, save the LCL. At that point, I balance it. Tight medial collateral ligament. You want to make sure that they're equal. You don't want a tight medial, tight lateral. I flex it back up. Put tractors around the tibia. Measure the tibia. Tamp it in. Size it, put the implant in like this, and I try it. Once I have the trials that I think work, we check flexion and extension, check our flexion extension gap. At that point, we mix the bone cement, which is polymethylmethacrylate or methylmethacrylate.
It's kind of a derivation of super glue. Then. It's acrylate glue.
Yeah, so you get that, you put it on your implant. I do the tibia first. I don't have this plastic on there. I have a little trial on it. Everybody does. You cement it out. You cement your patellar button. Once I release the tourniquet, neutralize any bleeding. Check the back of the knee because there's a big artery back there. You don't want to get that.
Make sure you're not nicked. Right.
And then by the time I've had it out and I've cleaned up the knee, any bleeding, you know what poly you're going to use. You pop your poly in and you close it up. You close the retinaculum, you close subQ, and then you do the skin, put a big dressing on it. The next day I get them up, start moving them. Some people use a CPM, which is a continuing passive motion. The research studies show that the CPM doesn't make any difference.
Right.
Okay. It makes a difference.
That was my experience with my knee repair.
It makes a difference at 2 weeks only. There's about a 5 or 10 degree increase at 2 weeks. At 6 weeks, there's no difference. You're not going to let a machine hurt you.
No.
You're not going to let a person hurt you. You're not going to let a machine hurt you. The only thing the CPM has been proven to do 100% is make you lose more blood and make you use more pain medicine. So a lot of people disagree with that. And a lot of people will disagree with that and will argue with that, and I understand that. I'm not saying it's not good to use because I've used it on patients. That patients ask for it. I say, yes, we can use it. So I'm not criticizing.
Absolutely opposed.
I'm not criticizing it. Right. I'm saying what I do. I used to use it in training. I mean, I didn't use it in training. I used it when I started private practice, and the only reason I used it because everybody else was, and I wanted to be just like them. And then at some point,
your own preferences.
And a CPM, just like any other machine, it's made for the average person. And nobody's the average person.
Constant passive motion. We define it.
Continuous passive.
Right. Continuous passive motion machine. And it just operates your knee back and forth kind of slowly and stuff.
Right. And so a lot of people say, well, and I hear this a lot, and I hear, well, my husband or my grandmother or a friend of mine used it and they had a good result. They had a good result because they likely put the time in physical therapy. Your therapy progresses direct effort that the patient puts in.
Right. Always.
I have patients that come in with bad knees and they're sitting up in a chair the very next day, flexing their knee at 100 degrees. That patient doesn't need anything. That needs some home exercises.
Right.
Hey, work on it, slide your heel back. You're going to do fine. At 100 degrees, you're fine. I have patients that come out and they won't move their knee for 40 degrees.
Everybody's got different tolerance for pain. Everybody's different laziness.
Right.
Different ambitions.
Knees hurt more than hips post-op. They really hate you for 2 weeks. But most of the time, by 6 to 8 weeks, they forgive you. So that's the basis of a hip and knee replacement. There's a million things you can go into this. There's I don't know how many orthopedic surgeons there are in the nation. I think 10 or 20,000. And so that means there's about 9,999 or 19,999 who are smarter than me. But that's the basics of hip and knee replacement.
Oh, shit. All right. Let's go back to the tourniquet situation.
Okay.
All right. When you set a tourniquet, has it been your experience that the tourniquet causes problems for proprioception in that leg post-op? In other words,
the ability to feel uneven surfaces.
The ability to tell your leg where it is in space. Does that have to be reset? What's the situation with that? Because that's a potential concern especially for like a younger athlete. If you have to do knee surgery on a younger athlete who's expected by his scholarship program to get back on the field, what happens with respect to the tourniquet?
Okay, and I'm not trying to use this cliche every time we answer a question, but let's back up on rehab. When we talk about rehab, there's 4 phases of rehab. There's 4 phases, okay? There's the inflammatory phase, okay? So basically that's the first part of rehab, is to get the swelling down, okay? The second phase is to get the range of motion back.
All right.
The third phase is to get its strength again, okay? The fourth phase is function. Proprioception falls into that.
So that's late in the process.
Right. So if you speed any of those processes up or skip it, you're not rehabbed correctly. If you get your swelling down, start strengthening, then you're going to be strengthening a joint or an injury
it's still swollen.
If you get the swelling down but start working on strength, you're going to be working on a joint that doesn't have proper range of motion. So you're going to be strengthening a joint through a limited range of motion. That's not good for anything.
Right.
You know? So you have to get the range of motion back. You have to get the swelling down, you have to get the range of motion back. A lot of times you can do that together.
Right.
Then you get the strength. Okay? Once you get that, then you have all the tools you have to perform your activity, whether it be walking, whether it be powerlifting, whether it be playing football, whether it be playing basketball. People like to skip the function part.
Right.
They like to skip it. Oh, well, I'm strong and I've got full motion. Well, I can go back and play football. No, you can't. You have to. There's certain things you have to do to be a football player and a basketball player and a soccer player. You have to be able to cut. You have to be able to change position. You have to be able to feel proprioception.
Yes.
And proprioception is extremely important.
And proprioception, for those of us that don't know what that is.
And I just to describe it's the ability to feel uneven surface. It's the ability for your body to feel where its foot is in space or it is in space.
The ability to identify your position with respect to your environment, surfaces, water, whatever it is.
With a knee replacement, when you have a tourniquet on there and you've squeezed these muscles, yes, proprioception is very important. And you would be surprised the amount of people that take their first step and they feel like their leg is going to collapse because they don't know where it is.
I remember very clearly.
I don't know where my knee is.
Remember very clearly having that happen.
So that is a vital part.
And that's a function of the tourniquet.
Some of it is. Some of it is a function of having your quad tendon cut. Some of it is a function of having your bone cut.
If the quad tendon was cut.
Yes. Well, the quad tendon is cut. It's cut longitudinally.
It's split.
Yeah,
it's not
split.
It's
part
not
of the retina
section,
yeah.
but right.
Yeah, absolutely.
Right.
Absolutely.
Okay. So proprioception is it. So if there was a way to do a knee without the tourniquet, would that be better post-op?
Pain-wise, function-wise, rehab-wise, my answer to that would be yes. I think so. And it would be difficult to do it to get true hypotensive, safe anesthesia to get a knee that's just not, and it's hard to explain unless you've seen it, that's just really bloody. You know?
Well, you can't see anything. I can understand why it's done. It's obviously we've got to have a clean picture of the anatomy or we can't work on the anatomy.
And my answer to that is there's a lot smarter people that figured it out, and I'm going to follow their lead until they tell me not to do it that way.
Right.
I mean, because the guys that started joint arthroplasty, they figured it out, and I guarantee you they tried every way possible until they found the technique that worked the best.
All right, now we know how the procedure takes place, and I think this is good information for a lot of people because there's just, I mean, this seems like it's awfully complicated, and it is awfully complicated, but how many of these have you done?
Hips and knees?
Yeah, how many hips and knees have you done? You have an idea?
Just joint replacement?
Yeah.
Around probably 200 a year for 17 years.
150, 200 a year for 17 years.
And that doesn't include hip fractures, and you put implants in on some hip fractures, so I don't throw those in there.
So, several thousand.
3,000.
3,000 or 4,000 of these things. And the experience of having done these makes the procedure faster, and it makes the procedure much more reliable. So you're reproducing what you've already done hundreds and hundreds of times, and you're real good at this, right?
I don't
Now,
let's back up.
no, I think that's an honest.
I think surgeon success
assessment.
is based on experience. And here's the greatest quote I've
Right.
ever had, and this was from a guy at the VA that I trained with, Dr. Walter Solakovich. He was awesome. Done it for a long time. And you know, good results and good decisions are based on experience, which are based on your bad results and bad decisions.
Right.
You know,
right.
so
that's what you learn from.
Right.
Yes.
So you know, my volume of these is relatively high. A lot of guys don't like to do them, and I understand that. I like just they choose not to. Good surgeon, bad surgeon. I think a good term is you're experienced. You have a volume of them. You've seen a lot of them. I think that's a good way to
Right.
put it. I think
Right.
so.
Well, I would much rather go to a guy who's done a procedure 3 times that day, and me be the 4th one, because I have a higher degree of confidence in the outcome, since he's more than likely, you know, real good at this. You know, you don't want to go to a knee replacement guy who's done 3 this month, right?
Right. He may do an excellent job of those 3.
He might,
Right.
but it's more likely
Right. And so
that
the
a
best
guy
way,
that's done 3 of them that day is going to have done a better job because of the experience.
right. And the
These
best way to
are-
explain that is that nowadays, if you know, a lot of people get their medical information from billboards and the internet and
Pharmaceutical company advertisement.
So you hear this big push for robot assisted knee replacement, and I get it, and one of the big things for robot assisted knee replacement is they tend to promote their procedure by criticizing other procedures. Well,
Right, criticizing your experience,
yeah,
essentially.
The most recent study of 11,193 knee replacements done, half robot assisted, half without the robot, have shown there's no difference.
None.
And the independent variable, here's the variable, and I think the number is 100. If your surgeon's doing more than 100 of these a year, and it may be even lower to that, there's really no difference. The robot is an excellent tool. It makes cuts on the femur and the tibia. It doesn't open the knee up. It doesn't balance your knee. It doesn't cut the patella. It doesn't close it. Doesn't open it. Doesn't take out the meniscus. Doesn't balance it. What it does is it gives as precise a cut on your femur and your tibia that you can get.
Right.
If you do enough of these, your cuts with the guides that you use. It's not like you're just freehanding it.
Right.
You have guides and you have to nail them in, and they're stuck. They're not moving.
Right.
Are negligible as compared to a robot. On the hip,
Well,
the robot.
You know, this is an interesting observation. If experience is the critical factor in terms of there actually being no difference in outcome between this precision robot and the surgeon, an inexperienced surgeon could benefit from a robot. B, that guy that's using a robot is not going to get the experience.
That's true. That's true. And once again, I'm not criticizing the robot
Right.
because I know some experienced surgeons that like it, and they want their
Right.
cuts to be exactly the same every time. And my answer to that is your preference. Don't criticize the other procedure that works to promote yours.
Right.
My second follow-up to that is when you do a revision knee replacement, which means you take out an old implant or a failed implant or an infected implant and put a new one in. There is no robot that does that. So revision knee replacement is a direct relationship to experience of the
Surgical
surgeon
experience.
and technique.
Right.
And so that's my follow-up to that. And that makes sense to me.
Right. But I could see that an increased reliance upon these external aids would, over time, have a detrimental effect on the surgical community's ability to accumulate experience on this thing. You know, and I don't know if that's a good thing or a bad thing, but certainly it's a factor.
I think it's a factor in anything. I think if you use a computer for months and months and months, and then somebody asks you to write a letter,
with your hands.
It's hard to do.
They can't
you can't. Your cursive isn't as good, even though you know how to do it.
Everybody's writing left-handed now. Is what it looks like.
But I understand that technology is moving in that direction. If 5 years from now a new study comes out and says, hey, the results are changing, we've made improvements in the robot, it does a better job. At that point,
I'd have to reevaluate.
Absolutely, I would. I would get on board and say, okay, then let's start the process.
Mm-hmm.
When that becomes the answer, then that is what you should do, I believe. But right now, you have a choice. The surgeons have a choice. I think some use it, some don't. I'm not. Once again, I have lots of colleagues who use the robot and like it.
Well, here's an even more important question. When a patient presents, and I've had this comment submitted on the forums quite a bit over the past 15 years that we've been running this damn thing. When a patient presents in the surgeon's office with a clear hip replacement situation, he's got hip pain, and once again, as Owen mentioned, hip pain presents in the groin, not lateral. It presents medial, and it's going to radiate down the thigh, and you may think something else is wrong, and you go to the doctor, and they have you do a standing x-ray, and you've got bone-on-bone arthritis in the hip. I've had lots and lots of people tell me, well, he didn't want to do a hip replacement because they're afraid they're going to have to replace it again in 10 or 15 years, and we want to get as much mileage out of the original equipment hip as possible before we go in and replace it. And I think that is crazy. I don't think it's just stupid. I think it's crazy. Because if you can't move, boys and girls, if you can't move, you can't train. And if you can't train, you can't maintain your muscle mass. And what happens to your quality of life? And Owen mentioned quality of life earlier. And this is a terribly important thing to think about. So tell us what your thinking is on this, because this does happen all the time, doesn't it?
And it does. And I see a lot of people and patients that come to my clinic, and they've been told they can't have surgery, and the majority of it is two reasons. One, they have a significantly elevated BMI, okay, so they're carrying a lot of excess weight. Or number two, they're too young. When I first started in my training, there was a hard and fast rule at the VA when we saw patients, nobody gets a knee replacement before the age of 50. That's kind of what you taught, you know. Now, when I got out, I saw a high, not every patient, but I saw lots of patients, or an abundant amount of patients that came in with hip and knee arthritis, or a dysplastic hip. They were born with hip dysplasia and have a bad hip, or they had a tibial plateau fracture, or the end of their distal femur fracture, and they were trashed.
Some other reason for the surgery that didn't involve bony arthritis.
And as people became more active in life with sports, and especially with the increase in women competing in sports at a younger age, there's a lot more wear and tear of joints. So this is my opinion on it, and I have done hip replacements in somebody as young as 17 who had a dysplastic, painful hip, no quality of life.
I've had people in the gym like that several times.
Knee replacement, the youngest knee replacement I've done is in their 30s. Done many in their 40s, and I get more and more every day. And and this was told me by a joint replacement surgeon, because I called him and asked him. He said, "This is what I tell my patients," and he believes it, and I believe it too. When would you rather have a better quality of life? When you're in your 30s or 40s, or in your 60s or 70s? My answer is in your 30s or 40s.
Well, yes.
If you're active and pain-free in your 30s and 40s, you can do the things to your body that it needs to do to be healthy when it's in your 60s and 70s. If you wait till your 60s and 70s and you've had an arthritic knee for 25 years, what are the chances that you've been out walking,
having
lifting
fun,
weight, sleeping?
Something as fundamental as that.
Going on vacation with your family and being able to walk and look at things. Right. I mean, if you haven't done those things, you know, why
have you been here? You know,
and so
what have you done all right, so this is so obvious an analysis that it really needs to be emphasized as often as we can emphasize it, and I do this on the board all the time, but look at this. People, this is your responsibility. If you're miserable and you can't walk, and the doctor you go to tells you that he wants to wait 10 years because they don't want to have to revise this surgery later on, get another opinion. Get another opinion. This is terribly critical. You're the one that's not sleeping. You're the one that's sitting around on your ass because you can't move, not him. And you're the one that needs this fixed. And you cannot allow medical authority to keep you from quality of life. That's just all there is to it.
Right. And any physician who is offended by a second opinion isn't a physician that you need to see.
Right.
There's nothing wrong with getting a second opinion. There's nothing at all. There's nothing wrong with asking for your x-rays, seeing somebody and say, hey, I know I'm young. This is what I'm told. What do you think? And the decision for surgery has nothing to do with you on your podcast, your physician. If your surgeon is willing to take the risk with you to do it, the decision is up to you.
It's your knee.
Right.
It's your hip.
Right. Nobody can force a physician to do it. And I don't recommend people go out and doctor shop. I can't stand that. But if the opinion,
but by the same token,
and just because you get a second opinion doesn't mean that's the right opinion.
No.
Maybe the second opinion is wrong. Maybe your
it
first
could be that the second
right.
opinion is wrong and the first opinion was right. That's absolutely true. But what it all boils down to is the simple fact that it's your hip. It's not his hip. It's not my hip. It's your hip. And if your hip is preventing you from enjoying your life and from doing the things that you know you need to do to continue to enjoy your life for another 30 years, then you need to get another opinion. And this seems terribly obvious, doesn't it? But I think that people are just, well, the doctor said.
I get that. And a lot of physicians are, and I'm biased, physicians are trying to protect their patients. But this is what I tell a patient who's young and that we're going to undergo a hip or knee replacement. I'm like, look, there's risks to it. The likelihood of you having to have it revised is going to be high. If you're willing to accept the risks, then let's get this done. If you're having it done when you're 40 and you're 55 and it wears out, you and I can have this discussion on 55 what to do next. That discussion might be, hey, we need to revise this. The discussion might be, hey, you know what? You got a good 15 years. Let's modify a little bit of our lifestyle and realize that there's some things that you were fortunate enough to do the last 15 years you can't do anymore.
Right.
And
now, that's obviously the case, but here's another scenario that I don't think is considered often enough. You've got medicine advances. We've got medical advances that take place all the time. We have advances in technology. Not all of them as basic as this, but we have subtle advances in manufacturing techniques, in metallurgy, in material science that make that potentially replaceable without much revision into a situation where it wouldn't ever need to be replaced again. You don't know. What you do know is that if your quality of life right now is bad enough that you can't do the things you need to do, then something must be done. And if you can afford the surgery, if it's available to you, God help you if you're in the UK, right? But if things are available to you and you can take advantage of them, you need to do it. And it's just a damn shame if you let somebody scare you into not getting your knee fixed when your knee needs to be fixed.
I agree with that.
Yes.
And to jump from this subject to the subjective, and people ask, why is it important to have strength to have a painless knee or a near pain-free hip or near pain-free knee? Because activity prolongs your life.
Let's talk about that study you've got with you on the table. This is, boys and girls, we talk about this all the time. And listen carefully, okay?
So if you pick up a magazine in the grocery store or anywhere, you go to a health website, unfortunately, you see unclothed male men showing their pecs and their biceps.
Yeah, at 4% body fat,
Okay.
that sort of shit.
So the actual scientific proof, and this is an older study, there's multiple studies. The Health ABC study shows that leg strength is an independent variable for life expectancy. So that means
It's an independent predictor.
So if it's directly proportional, your leg strength is directly proportional to your life expectancy. All the way back to 2006, that showed that lower muscle strength in adolescence is a predictor of mortality. The stronger your legs are, the lower risk of mortality you get, and that's an adolescent study. That's falls into adulthood.
Right. Right.
There's-
And it's not hard to understand why this would be, is it?
No, and I'm not saying, and you can jump to, anybody can give their opinion on that, but this is scientific. This is scientific studies it's your opinion.
These are actual studies.
They're actual,
These aren't
and
exercise science studies.
They're proven.
These are actual studies.
So what does that say? That says that lower body strength, muscle strength, increases your risk of living longer. No, that's not saying if you go strengthen your legs, you're going to live longer. What that means is that
Correlation, causation kind of thing.
The more active you've been, the more likelihood it is that your legs will be strong. The more likelihood everything increases. There's a study in here that shows leg strength is a direct relationship of cardiovascular death.
Right.
You're less likely to have cardiovascular death if your legs are strong. And that's because you've been active.
This is a correlation. Do you understand why? If your legs are strong, then you have been active. If you have been active, then everything else that you've done is more likely to be a contributing factor to longevity. So we're seeing essentially leg size, leg strength is a proxy for the lifestyle that keeps people living longer. This is an important thing to understand. But by the same token, if your knee pathology, your hip pathology is preventing you from doing the things in life that keep your leg strength high, then that is also a proxy for a sedentary lifestyle. And because if you can't move, you're sedentary. And
a sedentary lifestyle has been proven to be lower lifespan.
It kills you. Not only is it less fun, and it's a lower quality lifespan, it's a shorter lifespan. And, I really hate it when people post stuff on the board that indicates that their wife or their cousin or their father has been told to not have this kind of a procedure done, because it's irresponsible. It really is. You're not really thinking of your patients. When I'd hate to say this, but I think if you place your own professional liability ahead of your patient's well-being, then you're not a doctor I want to see. You're really not. Owen has got this absolutely right. You guys, your quality of life is intensely dependent on your ability to use your body. And if you need a knee and you need a hip, then get the damn thing, okay? Go ahead and get it. And, how often with one of these operations is there actually an adverse outcome?
I think most surgeon complication rates, if you put everything in there, infection, pain, all the things, it ranges, infection rate is about 2%, maybe 1 or 2%. Other problems, 96% success rate with knee replacements,
That's awfully good odds. It certainly is better odds than the thing healing up by itself, isn't it?
Yeah, that's not going to happen.
Yeah, which doesn't occur.
And hip replacements are very patient-satisfying surgery. Patients are very happy with hip replacements, and if your hip has got to the point where it's that bad and you get it fixed and you're pain-free, I mean, your life changes. Your life changes. You walk, you become active, you do things you haven't done before, and it does make a difference. And I'm not just promoting it because I do it. I see it every day. And
well, you care about your patients, and more important than that, you may have to have this done yourself one of these days.
I hear you.
And it's good to have thought in advance. And what we're asking you to do is to think in advance. This may not be an issue for you right now, but if at some point in the future, or if it has a bearing on somebody you love right now, this is good surgery. This is important surgery. We train people in the gym all the time. We see people every month at a seminar, 2 or 3 of them have had a knee or a hip. They all squat. They all deadlift. They all can train. They're all active. Every one of them is happy as a clam that they had this thing replaced. And it's something for you to consider. And look, don't call Owen's office and bother him about it. He's got all the work he needs. This isn't an ad. This is a public service announcement. Okay.
And my recommendation,
if you need the thing replaced, get it done.
My recommendation is don't look for a technique. Don't look in a magazine on somebody's using this or that. Talk to a surgeon. If you trust him, ask questions. You're going to get the answers you want. You'll know it's right for you. And if you've had a surgeon that's an orthopedic surgeon that does these, and he's done things for you, him or her have done things for you in the past, trust him. Don't change surgeons for techniques. Go to somebody you trust, and that's the key. There may be, all hospitals, when you're in the OR, they're all the same. One hospital may have newer paint and shinier stuff, but you're still using the same implants, the same saws, the same scalpels, the same stitches, and the rehab.
And the variable is the doctor.
Yeah.
The variable is the doctor. Thanks again.
Thank you.
Thanks for being here. This is a wonderful discussion. I hope that you guys have learned something today. And if you've got somebody that needs this information, forward this shit to them, okay? This is terribly important that people understand why and when these things need to be done, and don't be afraid to get it done. Thanks for joining us on Starting Strength Radio, and we'll see you next Friday.